Well, without any further ado, we have to get on with our work today. Presentation will be made. When it comes time for questions, you'll see me hustling around the room with the microphone. Please make sure at that time you wait for the microphone so everybody can hear your question and, of course, the answer that we're going to receive from Mary Jo Bowie. So it's my pleasure to be able to introduce Mary Jo. She's worked in the health information management field for over 30 years. She is owner of Health Information Professional Services. It's a healthcare consulting firm she started in 1985. Her business provides these health information management to all levels of health settings, including the hospitals, long-term care facilities, physician offices, clinics, drug and alcohol facilities, ambulatory surgery centers, and many more. She's also an adjunct instructor in the Health Information Technology program at Broome Community College. She's done that for 17 years, where she teaches medical coding, quality assurance, and computers in healthcare. As a registered health information administrator and accredited health information technician, she's written multiple books. She's spoken on the topic. Here's a few of the books. This is not easy summer reading like we talked about earlier. Understanding ICD-10-CM, Understanding Procedural Coding, Understanding ICD-10, and Essentials of Health Information Management. You know, as a young adult telling my daughter what I do for business, it was real easy just saying, I'm the telephone guy, right? I don't know how you tell your kids what ICD-10 is all about. But these kids, they're going to learn about it today. We're pleased to have you. Will you please give a nice warm welcome to Mary Jo Bowie.
I'm glad to join you today in this wonderful area in Florida that my husband would love to retire to tomorrow if he could. But you know what? I like the snow. So unless you get about 24 inches of snow in 3 hours in Florida, I think I'll be in New York for at least another winter or two. Well, we're here on not such a light subject, and that is ICD-10-CM PCS. How many of you are eager to embrace this challenge that we're all going to face as we move forward? How many providers do we have in the room? Do we have any providers of care? And none of those hands went up a little earlier when I said who's eager to embrace this. But you will. You will really like this once we get into this, because there will not be a doubt in what you treated the patient for, and it will be very clear to the payers what the services were rendered for, and that's a good thing. One of the things that we're going to hope that's going to happen, because it's projected to happen, is that once we can have ICD-10 in place, is the fact that we will be able to clearly state what was done. And so then the payers won't have to be requesting for more and more information. But the key to this whole thing is that the providers have an understanding of what ICD-10 looks like, so they can adequately document the information in the patient record. So what's our timeline look like for ICD-10? And this has become blurred over the last couple of years, because we were supposed to implement in 2013, and now we've got a delay until October 1 of 2014. So we have a whole nother year to really prepare ourselves and our organizations for ICD-10. Shortly, we will see the last and final revision to ICD-9-CM. That will be October 1 of this year. And then we will, in all good conscience, kind of sunset ICD-9. There's not going to be any more updates to that coding system. We'll look at ICD-10. We'll do some minimal updates for that October 1, 2014 implementation. So that's what we all need to keep in mind. We have a little over a year And in some facilities, that will be more than enough if you've already started to move in this direction. But if you haven't started to address ICD-10 yet in your workplace, you need to get busy and you need to start right now after you leave today. Because there's a lot of things that have to be looked at and covered, and we'll talk about that. If you have any questions as I'm presenting, feel free to raise your hand, and I'll field questions as we go through this. So what are some of the differences between the two systems? How many people in the room have actually looked at an ICD-10 manual yet? So we have 1, 2, 3, 4, 5, 6, 7, 8 or so people out of this room. So probably not even 10% of the individuals in the room have looked at this yet. First thing that I'm going to recommend to you is that you go to the CMS website, or that you get a copy of the actual hard copy draft ICD-10 and start to look at it right now. One of the best things to do is to familiarize yourself with the layout of the book. There's not much difference for those technical people in the room who actually select that final code for a claim. You're going to see that ICD-10 is very robust. There's a lot more codes. From this slide, you'll see that now ICD-10 is an alphanumerical system, where in 9, we had very minimal amount of codes that started out with an alphabetical character. We had V codes and E codes. That's all we had in 9. In ICD-10, we'll find that every code starts out with an alphabetical character, and it's expanded. So because of the expansion of the characters that can be present in ICD-10, we'll see that there are now over 70,000 codes in comparison to the 14,000 codes we saw in 9. And I see some stares on faces in the audience. That's because, back to my earlier comment, when you submit an ICD-10 code, there will be no doubt what you treated that patient for, because now we need some additional information about the services that were rendered. So if you have any of those little cheat sheets that you use in your office that is stuck up on a little board, right, that has your top 100 codes, or you have a provider who routinely uses the same codes every time, those days are gone. Because if I'm sitting in a payer seat, I'm going to now say, oh, I got ICD-10. There's additional information that I want to know about that encounter. Okay? So we need to start to think about, the first thing I would do if I was an office manager is go back and steal all those cheat sheets, make copies of them, and then try to recode everything in ICD-10. And as an office manager, coder, if that's your responsibility in the office, that's what you need to start doing now. Look at what you code and what you will be coding in ICD-10. In terms of ICD-10 PCS, now that's the procedural classification system within ICD-10. That's also an alphanumeric system that has slightly over 72,500 codes compared to the 3,800 codes that were present in 9. Now don't panic if you submit anything but inpatient hospital claims. You're not doing away with CPT or HCPCS codes. The only part of healthcare that's moving to ICD-10 PCS is for inpatient hospital billing. Everybody else is still going to use CPT and HCPCS. Okay, so that's not going away. However, because there is some change in the format and the content of PCS codes, of ICD-10-CM codes, we now have to look at how our CPT and HCPCS codes match our diagnosis in a little different way than we're used to so far. In ICD-10, laterality can be a component in code selection. So in the code itself, and I'll give you some examples of this in a minute, it will show left or right side. So you know when you submit your CPT codes and you add your modifiers on, now we need to make sure that if we add the modifier for left, LT on, that matches with our diagnostic code very specifically. And that's such an easy thing to catch on a computer edit. So what I think is happening, and what I know is happening because I work with a number of payers, is that they're writing more and more edits in this year delay that will now match your diagnostic and your procedural codes. So if you select an ICD-10 code that doesn't say left, and you submit a CPT or HCPCS code and put the modifier of left on, guess what? What's going to happen? Who's going to guess what's going to happen? It's going to reject the claim. It's going to deny the claim. So there's some additional things that we have to think about as we move forward with ICD-10 that were important in 9 as well, but the codes didn't have to match in terms of laterality because in ICD-9 there was not a way to indicate left or right. Now we have that present. Also in ICD-10 there's a way to indicate an unspecified side of the body. I have a problem with those codes. I think they never should have put them in there. If you can't specify what side of the body that you did a procedure on, I think we have a little bit of a problem, right? Okay? So if I was a payer, what would I do with those unspecified codes? I would review them. If a provider's telling me they don't know if they did a procedure on the left side or the right side of the body, right? Then I would ask for review of that claim. So those are some of the things that we have to look at as we move forward. All things we can manage, but we just have to manage them ahead of time. So let's compare 9 to 10 for a moment and see what are some of the differences. In ICD-9, there were 17 chapters with those 2 supplemental chapters. Those were the E codes, which were for external causes, and the V codes, which were for circumstances associated with healthcare, not necessarily a healthcare issue or a disease in itself. Those were for history codes, immunizations, etc. So when we move to ICD-10, we'll see that there's 21 chapters and there's no supplemental chapters in ICD-10 at all. There are still E and V codes, but they have different meanings in ICD-10 as they did in 9. Okay? So an E code was an external cause in 9. In 10, an E code are codes for the endocrine system. Okay? Same thing with V codes, have different meanings. So the old V codes in ICD-9 were for those immunizations, histories, encounters with healthcare. Now they are Z codes in ICD-10, and they're expanded and provide us with more information about risk factors as well. We'll also see that in these new 21 chapters, some of the old chapters in ICD-9 have been broken apart. So the chapters for the nervous system now becomes 3 different chapters in ICD-10, the nervous system, a separate chapter for the ears, and a separate chapter for the eyes. That's because the eyes and the ears have been expanded in terms of codes because we have a left eye and a right eye. Okay? So if you coded in those systems before and you had that one magical code on your cheat sheet, chances are you're going to have a minimum of 3 codes, if not more, when we move to ICD-10. ICD-10 is all about being as specific as possible to get that claim to be very clean as it's processed. In 9, we had 3 to 5 digits in length in terms of the code itself. Okay? That has an impact on any electronic billing, electronic systems. Because when we move to 10, we're going to see we have 3 to 7 characters in length. So each character has the potential of asking or requiring more information about the diagnosis for the patient. Okay, so we've expanded the length of characters. So now I want you to think about your computer systems and anyone who puts or enters a ICD-9 code. Do you have enough fields, enough characters in your electronic system to expand to the full 7 characters in length as we move forward? So you need to be having that ongoing active discussion right now with your software vendors. Where are you in this transition? Where are they? If you have pre-populated codes in any electronic system you have, does your vendor have the ICD-10 codes ready for you right now to start to look at? I do a lot of consulting with physician offices. And one office that I've worked with for a number of years, we've gone from a paper record to a fully electronic record system now. And that's one of the things we're working through right now with our vendor, to be prepared to move ahead, to make sure that their system is going to accommodate the expansion of these codes. And a PCS code, do we have anybody from a hospital in the room today? Okay. Well, I'll just mention this very briefly. A PCS code has a full 7 characters and will always have 7 characters in a code. So for those individuals who are now selecting codes for procedures in a hospital setting, it's actually going to require a code with 7 characters each and every time. So if you're a provider that performs procedures in a hospital, as we move forward here, you're going to see more requests from the coders in hospitals for more additional information, to make sure you have that information present in the documentation so that they can select the proper PCS code. So that's going to change as well. Let's look at the format very briefly. This is for all the real technical people in the room that are going to select those ICD-10 codes. In 9, all the chapters had numerical digits. The supplemental chapters, those E and V codes, were the outliers, let's say. In ICD-10, the first character is always going to be an alpha character. So that's something we're going to have to get used to as we transition. And the second to the 7th character are alpha or numeric characters, depending on the chapter within the system. Also within some chapters, and we'll see this in some of the examples a little later, there's what's called a placeholder character in ICD-10 that must be added in the 4th, 5th, or 6th character position for some of the codes to be valid. And then a 7th character gets added to complete the code. But it is the coders or the providers or whoever selects the code in your office responsibility to add those placeholders in, because if you don't, your claim's going to reject when it's submitted. So we'll look at what some of those placeholders look like. So the other challenging thing is you've got to be able to count to 7 in ICD-10, because you've got to make sure you have 7 characters present. I tell my students, you know, using this system, now you've got to know your alphabet better, because you've got to start with the codes, A, B, C, okay? And then you have to be able to count to 7. So let's just do a comparison from a 9 code to an ICD-10 code to see what it actually looks like. And this is one where there's a nice one-to-one match, in a sense, from 9 to 10. Urinary tract infection, 599.0 goes to N39.0 in ICD-10. If we know that the UTI was caused by E. coli, we would use the 041.4. In ICD-10, we use the B96.20. You're going to see that in ICD-10, infectious and parasitic diseases have been expanded. For this particular code, for the E. coli, it gets further expanded to types of E. coli. So, if in your office, when you report codes, you are in the habit of immediately submitting a code that relates to the encounter, you might want to rethink that down the road. If you send anything out for pathology that's going to come back, and this makes all the business people in the office cringe because it affects your cash flow, right? Because you want to get that claim, you want to get it out, you want to get it processed. But I want you to rethink this, because I want you to wait until that pathology comes back to identify what type of organism that is, because down the road it has the potential to impact reimbursement in some settings. So the more you know, the more information you give to the providers, to the payers about medical necessity and identifying organisms specifically, the better you will be down the road. Because we have all kinds of managed care organizations looking at how many times we see the patient. Okay, so if we can prove that the patient has an infection in which it is difficult to treat, better to identify that on the claim if we can. So you want to rethink processing as well. If you know the information is going to come back within 2 or 3 days, then holding your claims for 2 or 3 days, I would encourage you to do that, just to give a clearer picture on what is present for that patient. Here's a myth that I commonly hear, especially when I talk to people in IT. No offense to any IT people in the room, okay? And a comment to me is, there's going to be a one-to-one match, right? Because that's how IT people kind of like to think, right? My brother's a programmer for IBM, so I know how he likes to think, right? And everything's going to go one-to-one, one-to-one. Well, sorry, it's not going to be that way. There's not always a one-to-one match of codes. There can be a one-to-many. In some code areas, there's one ICD-9 code that has the equivalent or the possibility of having 16, 17, 18 ICD-10 codes, okay? So that can create an IT problem. And it creates a coding problem too, because we're not just going to take a 9 code and push it to a 10 code and life's going to move on. There's got to be some decision making that decides what one of those 18 possible ICD-10 codes are the equivalent now. And that's where the real issue is as we make this transition. However, there's a couple tools out there. The federal government has put what they've called the GEM, which is the General Equivalence Mapping, that takes old ICD-9 codes, translate it to the possible ICD-10 codes. So for your office managers or your coders in the room, that's one place you want to start. Look at your old 9 codes, translate to what are the possible 10 codes that are in, that can be used in the system. Here's an example that shows how this plays out in some areas. And I could have picked many of these, but I just picked this one because it shows a number of things within ICD-10 that is present that wasn't present in 9. In ICD-9, if we had a foreign body in the year, went to 931, life was so easy back then, right? You know, you said, how do I explain to my kids what I do? They don't understand what I did before. Now they'll never understand what I do now, okay? ICD-10-CM, there are actual 9 possible codes because of some more key indicators within the code itself. First, having to do with laterality. Is it a foreign body in the left or the right ear? And then having to do whether is the encounter actually an initial encounter, a subsequent encounter, or a sequelae related to that foreign body being in the ear. So we would translate this. Here's an example of the codes for the right ear. It's T16.1. And then there's those X's, and those are those placeholders I talked about before. If we opened up an ICD-10 manual, what would appear in the manual itself is a listing that says T16.1. There'd be a box at the category level. The category level is T16. That would tell you that a 7th digit is required, which is the A, D, and S in this case. And then you, as the coder, place the placeholders in that 5th and 6th character position when you submit the claim. So T16.1 XXA is the code for a foreign body in the right ear for the initial encounter. So that's the other thing you need to be able to capture as well. Is this initial encounter, or is this a subsequent encounter relating to that foreign body in the ear? The other thing that becomes critically important, and on the physician office side, in the past, I would venture to say, after working in this field longer than I really want to admit anymore, is that we did not always document very well if it was an initial or a subsequent encounter in the progress notes that we're looking at. Okay? Now we have to capture that information somehow in the process. The ideal thing is if we have an electronic health record system that tells us that. The other thing we need to look at is the official coding guidelines that relate to the interpretation of these codes. If you purchase a code book from any of the major publishers, or you go online to the CMS site, you need to look at the official ICD-10-CM guidelines for reporting and billing. And in there, it's going to give you definitions of what an initial encounter is versus a subsequent encounter. Okay? This is one of the easier ones in terms of the 7th characters. If you are, or if you work in orthopedics and you treat, or you work in primary care or an emergency department, and you see those sprains, strains, and fractures in those particular areas, there are multiple extensions, or 7th characters, I should say. They used to be called extensions. Now we're just calling them 7th characters. There's multiple 7th characters that are put in place. Not only does the code require us to know if it's an initial encounter, but is it an initial encounter for an open or closed fracture? If it's a subsequent encounter, we have to know the type of healing there is. Is there routine healing? Is there delayed healing? Is there malunion of the fracture? So there's additional things that we have to know. In some of those cases, there are 15 or so possible 7th characters that should be present as well. Again, it's all about being specific. So if we just look at the remaining codes for the left ear and then codes for the unspecified ear, we'd see there were 9 possible codes for the old code of 931. Here's the possibilities of 9 codes for the foreign body. So the best thing is to make sure that your providers are aware of the fact that these coding changes and the format of the codes and the complexity of the codes is expanded so they can further document this, or you can easily obtain that from the record. Let's talk about diabetes for a moment, because that's a pretty common code that we usually would submit. An example from ICD-10, this is what's known as a combination code, where ICD-10, in some cases, has taken 2 disease processes, or a disease and a manifestation in this case, and now put it into one code. So for years and years and years, we've told providers, or we've had coders select 2 codes for diabetes. A diabetic with a complication, we always had to have a secondary code for the complication. Well, now ICD-10 puts that into a combination code. So in some cases where there was a one-to-many, in other cases where there were more than one code, we go into one code in ICD-10. Again, it's just a matter of becoming familiar with what diagnosis that happens with. The new coding guidelines, as I mentioned before, you need to become familiar with the guidelines because as the format of the code set has changed, so has the guideline. And in relationship to diabetes, the new guidelines say to assign as many codes within a particular category as are necessary to describe all of the complications. So if you have a diabetic that has multiple complications from their diabetes, you're going to select additional codes for that. Okay? So if you have a diabetic that has complications involving their eyes or their cardiovascular system, you're going to have at least 2 codes for that. So that's going to be an expanded number of codes that you are going to report. And if you look at what has happened when we've coded current cases that we currently treat, we find the need to report more codes because of the specificity in 10. So that's going to happen as well. Assign as many codes from the E08 through the E13 category, that's the categories for diabetes, as are needed to identify all the associated conditions that the patient has. So that's something that is going to expand. Let's just take just a real brief look. There doesn't appear to be anybody in the room that's going to have to deal with the PCS component of 10, but I just want to show you what it looks like, how it's more specific and detailed. In 9, we had a numeric character, which would involve 3 to 4 digits with a decimal after the second digit. That was a proper format. Okay? In ICD-10, we have alphanumerical codes that are always 7 characters in length, and there's no decimal point. So that means some systems have to be changed as well. So you'll see that the code looks very different on the PCS side. So we would find a code such as is on the slide here that shows a full 7 characters. See the Z's at the end of the codes in PCS indicate that there are no value within ICD-10, but they must be filled in for the claim to be valid and processed correctly. This is what a table looks like on the PCS side, and I just want to show it to you because there's been a lot of talk as we rolled out ICD-10 across the country. Coders really like ICD-10 PCS. They feel it's a very complete system. It can code procedures very adequately, and it's very different from any other procedural system that we've seen. So it's very different from HCPCS and CPT codes. But in ICD-10 PCS, everything is table-driven. And if you look at this, the first 3 characters represent the section, the body system, and then the specific operation. And then you add on additional characters in the 4th, 5th, 6th, and 7th position, depending on the body part, the approach, the device that remains in the body, and then any type of qualifier that relates to that particular procedure. So it's very easy to expand this procedural system. So coders really like this in comparison to other procedural classifications that are out there. So that's why I want to show it to you. See the detail under the body part as well? So payers will specifically know exactly where the procedure occurred. So stay tuned to see if we ever expand this into other areas of healthcare. So what are the areas?
Does that mean, I know you said that providers that are not working in the hospital will have to deal with this, but what if our surgeon does procedures in the hospital? Would you be required to code that way? Or
No, if your surgeon completes procedures in the hospital, you're still going to submit for the professional component of your their service, the CPT and the HCPCS codes. The hospital on the inpatient side would submit the PCS code. So nothing's going to change on the professional side. Okay? So what and where is ICD-10-CM going to actually impact? It's going to impact claim submission, right? Electronic systems that contain some code. So any system that you have that has an ICD-9 code is going to change. Paper records that have pre-printed codes on them, that's becoming more an exception than to the rule anymore. Disease indexes and any type of data collection and health information management and coding or encoding systems are all going to be impacted with the addition of ICD-10 being put in place. Electronic record systems, and this is where you really need to, right at this moment, start talking with your vendor and make an assessment of the readiness of any electronic record system that you have, because I've seen the good, the bad, and the real ugly in terms of being ready right now to make this transition. You need to make sure you contact those vendors and determine when their testing would occur. In my opinion, they should be able to test right now. You should be able to start to test in a test area to see what your claims submission would look like, to see what your electronic record would look like with an ICD-10 code right now, and start to talk to vendors, start to talk to your providers. One of the offices I work with, we are in the midst of doing physician education. One of the things that I have the office managers doing is to, I go into your electronic system and run for me, get me a report that says what are the top 100 diagnoses that we bill from out of this practice. I looked at those and I took those top 100 diagnoses and I converted them to ICD-10. And then we have meetings with the providers and we say, okay, here's the top diagnosis we bill out of here. Here's what's going to look like in 10. So going back to our foreign body example, right, they would now know that in 10, they'd have to tell me left or right ear, because my rule is going to be I don't want an unspecified code that can indicate laterality, because I think you're asking for trouble. Okay, and you have to know initial encounter and subsequent encounters. So look at those diagnoses you most frequently look at and make the transition now. Break it down. You know, we've got over a year, so if you start with the top 100, get yourself a game plan, start to train your staff on those, and make it someone's responsibility. It really shouldn't be the provider's responsibility. It's got to be an office manager or someone in the practice, an office administrator, who can help start to make this transition. Because you can't stop practicing medicine to make this transition. You've got to get somebody to help you transition.
Oh, thank you. Mary Jo, so are the codes usable now? ICD-10 codes are usable now, or do you have to,
You're not going to report
the drop
them.
dead date?
Pardon me?
October 1st of 2014, it's drop dead time.
Is the drop dead
They're
date.
usable now?
They're not usable
now.
No, but you can use them in terms, if you have a testing environment, some of the facilities that I work with, we have an ICD-10 test environment, okay, where we're doing business as usual with ICD-9 codes, but we have a test environment where we're putting ICD-10 codes in to make sure that our system is going to process those correctly, okay? And not every organization or practice has the ability to do that, but you need to talk to your vendor and say, where are you? When can I test the system to see if ICD-10 is going to work? And depending on who you work with, you're going to get a variety of responses. Okay, but that's something you should be looking at now, because a little over a year isn't a lot of time, really, to get electronic systems to push in place. That's the two big things. Make sure your electronic systems work, and make sure your providers know what they need to document. Paper records and documents, you need to review all those pre-printed paper forms that you have. Excuse me. Review any cheat sheets or code listings that you have, and anywhere you have created any type of index or data collection, you need to look at that as well. What type of educational needs are there? And there's different types of educational needs. There's the HIM, Health Information Management, and coding staff. They need the most in-depth amount of education. Providers that document care need education, but they don't really need the nitty-gritty of how to select the code. They need to know, what do I need to document to get this claim paid? And then end users of the data. They need to be able to be familiar with and be able to read the types of data. So these are kind of three groups that you can divide your educational needs into. Now, some providers are right into this. You know, I work with some physicians who say, you know what, I want to know this forward and backwards because this is what's going to bring revenue or help justify the revenue that come into my practice. So I've done a lot of workshops where providers sit there in the high-level technical workshop and actually select the codes because they feel comfortable doing that. Most providers do not typically want to take that approach. They want to know what they need to document and then let the responsibility for the code selection fall on someone else. If you walk away with anything from today, I want you to walk away with knowing that you need to start this process right now. You really do. Many organizations were able and willing and wanted to implement this in 2013 because they've been on board with this for a number of years now. If you haven't started, you need to start now. You need to make an assessment of what your needs are, design that plan, put everybody in the room that this involves. If your codes are selected at the time the patient checks out, this is what happens in a lot of offices that I work with. The provider on either in the electronic data screen or on a piece of paper jots down a diagnosis, and then somebody at the time of checkout assigns a code. Well, if that occurs, that person needs to be involved in this as well. You need to develop a implementation strategy within your facility. Implement the training. Start to train now and then evaluate what our processes are and what needs to be changed as we move forward. My contact information, I've been told this has all been provided to you. If you have any questions, feel free to contact me. And I just want to open it up now for any questions or thoughts you may have in regards to this transition.
In addition to our regular curriculum, we also have the ability to customize, short-term training for our employers, things like that. Would this lend itself to that type of thing?
If you have someone that is credentialed within the coding and billing area, that's one thing that I would highly encourage everyone to do as you seek further training, is to make sure that you have someone who holds the proper credentials. There are many, many individuals out there saying, you know what, I can help your office transition to ICD-10, but make sure they come with a certification in coding, because it's becoming a science unto itself. When I learned this way back in 1979, as we were transitioning from ICD-8 to ICD-10, coding didn't have the impact on healthcare that it had today, right? In 1980, we selected codes. I see some heads going, yes, right? We selected codes and we threw them into a data bank, and we knew that in a facility that we treated X amount of patients with appendicitis. Well, now what does coding do? It drives all of reimbursement in healthcare. There's a joke in the health information management field that all coders used to be, and health information medical record professionals used to be in the basement of hospitals, right? Well, not anymore. Where are we? We're in the boardroom, right? Because I'm giving you data that tells you what your reimbursement's going to be like. I can give you data. I can run an analysis and give you data about your practice based on these codes. So you need to make sure that when you go for training, you get training by someone who is credentialed in this area.
And it is important for us to know whether if it's an appendectomy, whether it's on the right side or left side.
Oh, and that brings up another point. In ICD-10, it's very important that you know your anatomy, that you know where that appendix would be. So for your staff, that was perfect. You think we planned that, didn't you? For your staff that have always coded with the same old codes, okay, you're going to see in ICD-10 the amount of anatomy, pathophysiology, and med term you need to know is definitely enhanced. So if you're going to train your staff to be very accurate in code selection, you may want to make them have an assessment of what they know about A&P, what they know about pathophysiology, and what they know about medical terminology.
He actually stole my question. Actually, you just explained it, so I'll come up with an. I was going to also ask you about. I'm a trainer and developer for medical assisting, and although they're not billers and coders, they're going to become very vital into that process.
Right.
So, how fluent do you have to be in medical terminology? But you just answered that. So I'll go on to my second question. The subsequent visit. Could that possibly be in the EM codes as the visit, the type of visit? Would that be a hint as in the subsequent visit that you were talking about?
Not necessarily, because in an evaluation and management code, it's a established patient, which is a different definition versus what a subsequent encounter is in an ICD-10-CM code. So there are times that that isn't exactly matching, because you can be an established patient with a provider, but you could treat me for an initial encounter for the fracture. So it's based on, is this an initial encounter for the fracture, but you'd still be a established patient. And that question is very technical. So some of you are going, oh, these two are really crazy, right? But that is a real technical question, and that's why I said you got to go back to your guidelines. So you really have to know your guidelines. So if you have someone in your office who hasn't had, how do I want to say it, hasn't had formalized training and coding, now's the time to think about, do they need it? Okay, because there are some little subtlety differences that we're going to see in 10. And I would highly encourage every office to make sure someone from their office goes to training to really look at these little fine technical points, because to prevent what I guess your next workshop's on fraud and abuse, right? To prevent you being someone come knocking at your door in 2015 and really looking at the codes you've submitted. And I've worked with physicians who, with all good intention, were not out to take any money from anyone, but made coding errors and had to pay back money to CMS because there were coding errors. So I believe, you know, everybody's all panicking about October 1, 2014. I think that's nothing. I think in 2015, when we've all started to code in 10, and now all the audits are occurring, that's when it's really going to get interesting, right? Because if you didn't understand some of the fundamental concepts, just as what we've talked about right there, you're setting yourself up for audits down the road. Any other questions?
Yeah, I think only about 4 or 5% of healthcare providers are engaged at this time. How do you get the healthcare providers engaged in the ICD-10 transition? Because a lot of the ones that I'm talking to are relying on the electronic medical records. Do you think the electronic medical records are going to suffice?
I don't think the electronic medical records are going to suffice in every specific area, unless you've designed a system, and I haven't seen one yet, and I've worked in this for 30 plus years, that can actually pinpoint the exact code for you. You're still going to have to prompt through a series of screens to get to that specific diagnostic code. The one system that I work a lot with, because I help to make the recommendation of what they should use within their office, the provider still has to prompt through 3 or 4 screens to get to that code at the end, which is more than what they're doing now. Now they have a drop-down that has, you know, the foreign body code. Boom, that's easy. Now they're going to have a drop-down with 9 different codes they have to look at. Okay, so the best thing you can do is get as many providers in the room as you can by specialty and say, okay, for those OBGYNs, here's what you got to look at, because that whole chapter in itself is drastically changed. For orthopedic surgeons or anybody who deals with fractures and sprains and injuries, arms, legs, any bone, get those people in the room. Every specialty, endocrine, every specialty has their own little components that have to be addressed. And we got to get their attention, because it's going to be here before you know it. A year is not that long.
Yes, I have a couple of questions. First, for the provider or physician, they should learn this more than we do, right? I mean,
well, the provider and the physician needs to know what the descriptions at least look like, so they can document what's needed. Because if they don't document specifically what's needed within an area, the codes, you're forced to choose a non-specific code. And we really don't want to choose non-specific codes in terms of justifying medical necessity.
because if they don't learn all these things themselves, like for us as a radiology center, if they don't put the right ICD code or right diagnosis, then we won't get paid for it.
Exactly.
And then we have to go back and continuously harass them. Hey, this is not the wrong, this is the right one, this is the wrong one. And that's created a lot of problem for all of us.
Exactly. If you're performing any of the ancillary services, you need to get the correct diagnostic code for them, or your charges are at risk as well.
So we have a practice of psychologists and counselors, speech paths, OTs, behaviorists.
Mm-hmm.
How different is that coding going to be in a clinic setting versus a hospital setting?
It's going to be different in that the mental health chapter has been changed. The descriptions in 10 are significantly different at times than they were in ICD-9. And so that's one of the chapters. When I do a full day training, that's one of the chapters that I say, if you code out of those chapters, you really need to do a thorough analysis, as you do in any other area. But it is different in that area. Do you do a lot of, do you do drug, alcohol, rehabs as well? Okay. Yeah, there is differences within that system as well. Because the DSM-5 has changed. Some of the descriptions have changed as well in 10. So you really need to look at that. And everybody needs to do the same thing and analyze those most frequent codes you use. And that's what that's what you need to come to the providers with. Here's what's different.
Thank you very much for your presentation.
You're
I thought it was very good. We're also in the revenue cycle management side of business, and just had an insight we're a little curious about. As far as the 97 and 95 guidelines that the old system would use for levels of restriction or to kind of give that leniency when there's a lack of documentation, because we all know at the end of the day, the impact really comes down on documentation. If that provider's documenting accurately, coding is a cinch. It's when you have to pull it out of nowhere that you're trying to have those challenges. Do you know if there's any any interpretation similar to the 95 and 97 as far as leniency for ICD-10? Any updates on that stuff?
The 1995 and 97 guidelines that you're referring to are guidelines for the evaluation and management codes. Okay? There are guidelines for selecting ICD-10 codes that are present. That, you know, if you're designing a system that would incorporate those codes, you need to look at those official coding guidelines for diagnoses. So the 95-97 on the evaluation and management, that hasn't been impacted. But what you have to do is match what the diagnostic guidelines say to the procedural guidelines. Okay?
Hi, I'm Professor Ramsey with Florida Technical College. We are starting to provide some of this training, and some of the stuff that I found on the AAPC was they had stated that physicians need to get a credit line if they don't start training. How do you feel about what message are they trying to send?
That the physicians need to what?
Get a credit line to operate their business because they won't get paid if they don't start training now.
Well, you know, I can't speak to office management processes, but the reality is we need to start training now, and you need to have an implementation plan in place to make this happen. You cannot wait until 2014 to start this. Realistically, physicians should be well into this process. Right now, offices that I've worked with are over the last couple of years, because we were ready to implement in 2013. Many physicians' offices, facilities were ready to do that. Right now, we're really testing. As I said earlier, we're really coding in 9 and coding in 10 and seeing what the difference is in moving forward. I know that's not present in all parts of the country. Different places I go, it's very different in terms of how aggressive people have been up to this point in starting to do training. But you need to start now. I mean, you really need to start now.
Well, hang on. We got a question over here.
Hi, I'm Chuck Blystone with New England Financial. I do a lot of group insurance, and I'm on the claims side a lot with my clients, the employers, with their employees, and we get into the code conversations a lot because obviously the carriers are not going to pay the claim if the code's not correct. And so we have to go back, and a lot of doctors are not comfortable changing the code. I've run into that, but yet the carrier says, if you change the code, we'll pay the claim. All right? Here's my question. You're alluding, you know, and it's all, they have latitude to be able to do that, okay, with what you're saying, from what I'm understanding, under the current system. My question is this. It seems to me that with this new system, they're going to get more specific on the ability to pay, so that their codes are going to be more accurate, so that the claims are probably going to be more accurate in being able to be paid on a regular basis. What's the percentage of claims not being paid from a doctor's office or facility, and they're losing time? Do you know what that number is, approximately? Or they have to go back and have to redo things because the carrier's saying, we're not going to pay that.
And that varies from area to area. I know CMS did many studies, but these are 10, 15 years old, about the percentage of claims that were paid or not paid or had to be reprocessed. I know in New York what the statistics were from years ago. Right now, the claim processing is pretty good. I would say it's probably around 85 to 90% that it's paid the first time. But that has to do with people being comfortable with ICD-9, knowing what the requirements are. What's going to happen in October 2nd, 2014? I don't want to stick a number out there. I have one in my mind, but I don't want to say it publicly. If you're not ready for it, think back to that foreign body with those placeholders. When I teach this, and I've been teaching this for well over 2.5, 3 years, real experienced coders that sit in the room, or the people who come to a lot of my workshops, They forget to put those placeholders in. These are people that have a lot of attention to detail, and they're forgetting to do it. Okay. Will we have 50% of the claims will reject it? Will we have 75%? Time will tell. That's why, back to my 2015 and 2014 are going to be very interesting times, because there are claims that are not going to get paid because people are not going to be putting the full amount of characters required in the code.
I was just going to mention that it sounds to me like what they're losing is the profit margin of the practice. The cash flow, they're losing the cash flow, the profit that they're actually not getting because they're not seeing that extra, that 10% or 15%, what you just said. They're not getting that extra money, and that's actually...
Well, they should get the extra money if it's a payable service. But if they're not putting a correct code down and they have to rework, anytime you rework, there's a loss of profit, right? You need to get that claim out the first time correct. Once it goes out the first time correct.
All right, well, we're down to our last question, other than
Okay.
those that you might take after
Okay.
sticking around a little bit or during one of your own seminars that you do on the coding. So please.
I just have a quick question. I know different offices, every office is different, every specialty is different, but are there any sample implementation plans or resources we could have to maybe have like a baseline to assist our offices in coming up with a proper implementation plan for ICD-10?
A lot of the professional organizations, whether it's the AMA, AHIMA, AAPC, does have information about implementation and plans. So I would check any of those professional organizations.
Well, Mary Jo, thank you so much.
Thank
Will everybody
you.
give it up for her? What a fine presentation this morning.